Hello, my name is Dr. Michelle Miller. I'm a psychologist here at NYU Child Study Center, and I'm excited today to talk with you this afternoon about the relationship between obsessive-compulsive disorder, ADHD, and Tourette's disorder, as well as other tic disorder, and what that implies for treatment. I'll also be talking about some research and some different cases that have been occurring. So before we can even go into the connection between these disorders, I want to just overview each of these conditions so that there's a good comprehensive understanding of each of them. So starting off with tic disorders, we first need to understand what are tics. So a tic we define as a sudden, rapid, recurrent, non-rhythmic motor movement or vocalization, and these are involuntary. I often hear from people, could this be tic? Could this movement be tic? Could this vocal noise be tic? Literally anything could be a tic. We define tics into two different groups, motor and vocal tics. That helps with diagnoses, and I'll explain that shortly. And we also define them into more simple tics versus more purposeful ones. So with motor tics, some of the more simple common ones that we frequently see are eye blinking, head jerks, shoulder shrugs, tensing of certain muscles, particularly the abdominal muscles we see a lot, and facial grimacing, while the more complex motor tics are either a combination of tics, like I often see like a neck jerking tic with a shoulder shrug, touching or tapping, hitting or bending, or what we call dystonic tics, which is a movement that someone makes that is not a movement that a person would typically make with their body, such as the contortion of their torso. Vocal tics, the most common ones that we see are the simple ones, such as coughing, sniffing, snorting, throat clearing, humming noises, whistling. And for this reason, unfortunately, a lot of kids who present with these symptoms don't initially come to me or come to neurologists. They're first seen by an allergist because it appears that they may have an allergic reaction to something or that they're having seasonal allergies to a significant extent when they're actually just tics. And the more complex vocal tics is when they're actually using words, saying syllables. Believe it or not, even changes in tone or pitch can be a tic. Oftentimes in the media, tics are presented, or individuals with Tourette's disorder, as compulsively cursing, which is called cocopralia. However, that only occurs in 10% of the individuals with Tourette's disorder, so it's actually not that common. So what is Tourette's disorder? And this is where we get into why we differentiate between motor and vocal tics. And this is just purely for the labeling and the current diagnostic criteria that has been laid forth through the psychiatric community. So to meet criteria for Tourette's disorder, you have to have both motor and vocal tics. It may just be one motor tic, it may be just one vocal tic, they may not be occurring at the same time, but if they've both occurred and it happens for more than 1 year, then you would meet criteria for Tourette's disorder. Now, these conditions almost always occur before age 18, and I'll go over with the presentation in more detail shortly and the lifetime and how it changes over the lifetime, but it can, on rare occasions, occur in adulthood. Another common tic disorder is a persistent or chronic motor or vocal tic disorder. And that's when you have either just one or more only motor or only vocal tics, but not both of them. It only takes one, having an additional vocal tic or an additional motor tic when you've already had the opposite one to meet criteria for Tourette's disorder. And like Tourette's disorder, this has to have occurred for 1 year. And another thing to note with these conditions is that we expect tics to wax and wane throughout time, but that they won't, go away for many months at a time with these conditions completely. And then another disorder I just want to add in, though it's not, looked at in research, it's just a provisional tic disorder. And this is when someone comes in and it's been less than a year that they've been presenting with tics. It can be just motor, it can be just focal, it can be both, but it's been less than a year. So for example, I had a case that I've been seeing who came to me and they had been presenting with tics for 9 months. I've addressed the tics through behavioral interventions. Tics have come up, and by the time it was 1 year, then the diagnosis was changed to Tourette's Order. But this is just if tics have been present for less than 1 year. So somewhere around 1% or a little below of children meet criteria for Tourette's disorder. Interestingly, males are 3 times more likely than females to present with it. And these tics tend to wax and wane over time. And when I say over time, I mean from everything, from years through seasons, through the course of the day, during an hour. New tics may develop, each week in some cases. They may be short. They may be less frequent, during the school day and more common when they are home, or vice versa. They may be more common in summer and less common in winter. Each case is different in how they wax and wane. Important thing to know, though, with Tourette's disorder and other tic disorders, this is primarily a childhood condition. So it typically presents itself around the age of 5, and the tics from then on increase up until the teen years, and then from then they start to go down. And by the time of 21, only around 20-30% of individuals who had received a diagnosis of a Tourette's disorder present with a significant amount of tics. For the other percentage, their tics are barely there or completely gone. Obsessive-compulsive disorder is also like Tourette's disorder. It is more common in males than females. It occurs, as far as it goes with children, it occurs also in a small amount percentage, around 1 to 4%. However, unlike Tourette's disorder, this occurs more often in adults than children. Only 18% of cases occur during childhood in OCD. And a really important thing to keep in mind that while Tourette's disorder waxes and wanes and decreases most frequently by the time the child has reached adulthood, around the age of 21 in research, that they're gone or almost gone. With OCD, it's a chronic condition, and without treatment, it's likely to persist, into all of adulthood. Interestingly enough, there is a high connection between the presentation of even just obsessive-compulsive symptoms, not even the full disorder. So for the majority of cases of Tourette's disorder, there are some OCD symptoms. So they may be small, they may be just lining things up or doing things in a way that seem just right, or washing their hands more frequently, but not enough to meet the full criteria of OCD. But even so, OCD does occur often in Tourette's disorder, more often than in the full population, with our research showing a variation between 10 and 35% of individuals with Tourette's disorder. OCD, again, in the media, we commonly think of it as someone who has obsessions around things needing to be clean and orderly and compulsions around hand washing. Although that does present, and that is common, that's not the only common one. Many individuals with obsessive-compulsive disorder have a need for things to be just right, things to line up in a particular way. They have perfectionistic tendencies. Unfortunately, many of them have obsessive thoughts that they may say or do something that will cause embarrassment. Many of them, unfortunately, have thoughts that they will act in a way that may embarrass them, may cause harm to themselves, or cause harm to others, and they won't be able to control it. As a result, to address these obsessions, common compulsions are touching things in a particular way, counting things, checking things. They may be lining up things in a particular way. Mental rituals can be compulsions in which a person says or does things in their mind, maybe has certain thoughts they have to say in a particular way over and over again. And we frequently see in children reassurance seeking, so that they're going to their parents, their source of safety and security, and asking them questions over and over again, or going to them with concerns about their obsessions as a way to try and relieve them. And Tourette's disorder also has a very, very large overlap with ADHD. Like OCD and Tourette's disorder, it is another disorder that is more common in males than females. However, unlike Tourette's disorder, it does, continue very frequently into adulthood. It's not just a childhood condition. However, the symptoms change over time. We may see children who are hyperactive and bouncing off the wall when they're, 7 or 8. But when they're in their teen years, instead they may be just more fidgety. They, we're still seeing disorganization. We're still seeing some daydreaming. We're still seeing them zoning out. They may get a little better with following directions, and they learn ways to overcompensate with some of their difficulties, such as going to fields that have a lot of stimulation, such as working in an ER or a crisis center, where that would be very stimulating for them. There are 3 types or 3 ways that we currently label ADHD. It used to be that there was ADD, which was just having inattentive symptoms, and ADHD, which was just having hyperactive and impulsive symptoms. Now it's all under ADHD and just these 3 types. So the first one is hyperactive impulsive type, which would involve symptoms such as having difficulty sitting still, speaking out loud, and answering questions before the questions are completed, making silly mistakes, engaging in any other similar impulsive behavior. And there's also the predominantly inattentive type, in which they're often distracted, difficulty following directions, seem as if they're not paying attention, maybe forgetful in their daily activities, often losing things. And then there's the combination of all of these symptoms together. The connection between Tourette's disorder and ADHD appears to be very high, with many cases as many as 50 to 75% of individuals with Tourette's disorder also meeting criteria for one of these types of ADHD. So before I get into the research, I want to give you just some case examples that I've been working on, or that I have treated before. I've changed some of the genders and ages and symptoms to protect their confidentiality. But I'd like to present these cases to help you understand how it's approached in treatment when someone comes in with multiple conditions. So I had in the past seen an 11-year-old boy who presented with Tourette's disorder and ADHD. He had his Tourette's presented with occasional snorting tics and some tensing of his leg muscles. He just had those 2 tics. They didn't occur very frequently, but he had those, and it was for over a year, so he met criteria for Tourette's disorder. However, his ADHD was highly impairing. He was hyperactive impulsive subtype. He would often get out of his chair in class. He rarely stood still. He would speak up against the teachers. He was argumentative. He frequently did not follow directions. And he was at risk of getting kicked out of a school that was designed to treat children with special needs. But he was so disruptive in the classroom because of his hyperactivity and impulsive behavior that he wasn't able to contribute or to comply with school tasks. And so in this case, clearly the ADHD was the area that needs prioritization. So I did work with the school and the parents to create behavioral plans that would reinforce the behaviors that they want to see to a level of involving a level of reinforcement that was stimulating enough for an ADHD child, to build in a lot of structure to make things very predictable, and to help with creating an environment that was very organized. However, that was not, supportive enough on its own. So he was placed on a stimulant medication by a psychiatrist with expertise in this area, and it made a world of a difference. He was much less impulsive, much less hyperactive. He appeared to have more confidence as he was able to sit still and complete his work more easily, and took more pride. And of course was then receiving much more attention for all these great behaviors, which made him feel even better. So in that case, although I did some behavioral interventions, I was really focused on the ADHD symptoms and really need the support of a psychiatrist with expertise in this area to help with that. I've also worked with a girl, 13 years old, with OCD, ADHD, and Tourette's disorder. She presented with her parents with concerns about all of these areas. The ADHD was just inattention. And there is new behavioral intervention that can significantly improve attention. So I recommended a psychiatrist who specializes in this area to work with them to see if there was a medication that could help with her attention abilities, as well as to work with the school to provide accommodations such as extended time, as she was working slower with attention difficulties. Her Tourette's disorder presented with humming noises, sniffing noises, and stretching out her fingers. This sometimes bothered her, it sometimes didn't. Her parents were very concerned as these tics have been changing over time and going on for years. They were concerned that when she got older that she might be bullied, although up until this time, because they were very minor, and they hadn't interfered with her work or her completing anything, she hadn't had any peers or teachers' comments on these tics. And then there was her obsessive-compulsive disorder symptoms, which presented with her having concerns or obsessions that over and over again each night that God did not exist and that she did not believe in God, which was very counterintuitive to her values, and OCD often, unfortunately, brings that out. And her compulsion to address that was banging her head on her nightstand over and over again. So that was extremely bothersome to her and also of concern for the parents. And to give her a sense of success, and because that was a prioritization for her to address over the other conditions, we began work on what's called exposure and response prevention, which is treatment from cognitive behavioral treatment, in which a person gradually experiences their obsessions with support of their parents, a therapist, or if they're adults individually as well, and then they're not allowed to do the compulsions. And so they may be doing something else, or just sitting through the anxiety until it goes down. And over time, with my work with her on addressing this, I've had her parents support her at night with sitting through the obsessions. The obsessions and compulsions have begun to dissipate, and now we're able to work on reducing some of the tics. And then the other case that I want to present with you, which also has Tourette's Disorder, OCD, and ADHD, but looks very different. This is a child, again, with an inattentive type of ADHD, but this child, their inattention symptoms are not significantly impairing at this time. They were when they were younger, but not at this time. So they're not on any medication and not requiring any organizational skills training or behavioral interventions for that. However, their Tourette's Disorder and OCD overlap to a great degree, in which they're having obsessions that people around them are going to contaminate them with negative traits that they have. In order for them to address those negative traits, they are doing some of their tics. They do tics independently of their obsessions, but most often the tics are associated with obsession. So they're stretching out their arms and expressing that protects them from taking on these negative traits. And so they've been working with a psychiatrist on medication to reduce these symptoms as they're occurring constantly throughout the day, and I'm working with them on cognitive behavioral techniques such as exposure and response prevention, as well as some of the behavioral interventions we use with Tourette's disorder to reduce the symptoms. So around the past decade, all around the world, we have been collecting genetic data on Tourette's disorder and other related conditions. They brought in families where parents and children have tic disorders and often have other conditions such as OCD and ADHD that, as I mentioned before, often come up with Tourette's disorder. And they're taking blood samples to get a sense of their genes. And they're also getting data on their presenting symptoms and how they present in different members of the family. In one study that just looked at the family symptoms, they found that for ADHD to present in a child, it was most likely the case that one of the parents had ADHD. How, in contrast, when a child who already had a tic disorder and the parents had tic disorder, for them to present with OCD, it was not related to whether or not the parents had OCD. So this suggests, this is just one study, that Tourette's disorder and OCD may have a greater genetic relationship with each other than ADHD. However, of course, more research needs to be done to make this conclusive. However, this was a very large study. We've also found in research that when one member of a family happens to have tics, it's more likely that other members of the family happen to have tics as well, in comparison to OCD, and the likelihood that someone else in the family will have that disorder. As far as looking at the gene structures, like many conditions, there is no one gene structure that is purely responsible for Tourette's disorder, for chronic tic disorders, or for obsessive-compulsive disorders. There are many different types that we've seen that are related to them. However, we are so far finding some overlap between the genetic expressions of all of these conditions. The research is still early and there's so much more to do, but that's where we are at this time. There have been MRI studies that have looked at these conditions, all usually just looking at just Tourette's disorder, just OCD, or just ADHD. However, the issue with these studies is that they typically just look at it at one point in time. And as we know, these conditions are often change over time, especially Tourette's disorder. What we've seen so far is that there seems to be some connection with the basal ganglia region of the brain, which is responsible for a lot of motor control and connects to other regions of the brain that are also connected with that as well. But we definitely need more MRI studies that are looking at the brain at 8, at 12, at 13, at 15, at different ages to see how the brain changes over time with these conditions. So based on this, of course more research is needed. There's always that need. But what we do know, and you can see from the case I presented, that treatment will vary as these conditions vary in their presentation. And so we need to look at the individual in how we treat them while still using treatments that are evidence-based and found effective for these conditions in research. It's also really important to keep in mind that obsessive-compulsive disorder and ADHD are much more likely to be chronic than tic disorders. So even if tic disorders are the primary concern, it's helpful to teach skills to address those conditions, as they will likely be involved in the individual's life for a longer period of time. And just to quickly review, as far as the first line of treatment, I just put up here for these disorders, if they're going in for tic disorders, psychiatrists typically prescribe the first medication if they would prescribe one to reduce the tics. And you also want to keep in mind that with these medications, they don't take away the tics. They only take away them for the time they're on the medication. As soon as they're off the medication, the tics will come back again. We do have also behavioral intervention called comprehensive behavioral intervention for tics that reduces or eliminates the tics that are present at the time that the child or adult is seeing the therapist, and also teaches skills of how to prevent, not how to prevent, but how to treat and reduce tics that come up in the future. For obsessive-compulsive disorder, psychiatrists typically, the first line of treatment would be a selective serotonin reuptake inhibitor, such as Prozac or Luvox or Zoloft. And this can be very helpful, as well as I talked about before, exposure and response treatment as a behavioral intervention. And ADHD, as I mentioned, we can do a great deal, we can do some work with behavioral modifications, such as providing reinforcements, making the environment more structured, teaching organizational skills, but there's no behavioral intervention that can reduce attention or hyperactivity. The only way to address that directly would be through medication. There has been a myth in the past that if you have tics, you cannot take stimulant medication because they will definitively increase the tics. But research has shown, and I've even seen in my own clients, that that's not necessarily the case. Of course, different individuals respond differently to different types of treatments and different medications, and so we want to keep that in mind. You don't need to rule out stimulant medication if an individual has Tourette's disorder and ADHD. So I'm going to go to some questions now that I have. The first question that I have has been, has any gene or chromosome been identified that caused Tourette's or any comorbid conditions or any relations with Parkinson's? And by the way, you can submit any questions today by typing them into the questions panel of the control panel, which is on the right side of your screen. So there has been no, as I explained before, there's no one gene or chromosome that causes Tourette's or any of these comorbid conditions. It seems to be multiple different areas of genes involved. And Tourette's disorder, and the second part of the question was any relationship to Parkinson's. And with Tourette's disorder and other tic disorders, they are both, connected to Parkinson's, and that they're both motor control conditions. However, they are treated very differently. and there has not been any core connection between those conditions, as far as research has found. The next question I would ask, how would you approach treatment for a child with Tourette's, OCD, anxiety, ADHD, in addition to ASD? And I see a lot of these kids. So, you know, a lot of times anxiety presents itself. And so again, you know, with any of these cases, you know, I want to treat what's the primary concern, you know, whether it be the tics, whether it be the ADHD, whether it be the OCD, or the autism spectrum disorder symptoms. I would want to address those symptoms first. But what we want to keep in mind is when I'm treating a child with autism spectrum disorders, they often have less insight because of their condition. And so we can do comprehensive behavioral treatment for them, and I have been able to do that with kids who have autism spectrum disorders, but it's harder and we have a lower success rate with that particular behavioral intervention. Another question that just came up is, what's the relationship between OCD and anxiety? And, well, people who experience OCD definitely have the obsessions bring up anxiety along with it. And I don't have the stats with me now, but there is a connection and comorbidity between anxiety and OCD that is significant. And so there are a ton of behavioral interventions that we do for them. For OCD, like I mentioned, we do exposure and response prevention. For anxiety, sometimes if it's specific fears that they have, I would also do exposure in a gradual manner to the things that they're afraid of and avoiding. But I also teach them coping skills to manage their anxiety, such as doing diaphragmatic breathing, addressing thoughts related to anxiety, and helping them reconstruct some of those thoughts. Another question that came up, my son does a lot of inappropriate touching of others. How can we know if this is a tic or a compulsion? So that's a really great question. I actually had, you know, I wouldn't be able to tell that without seeing it. I think it's great to check in with a specialist. You know, I think if it's short and if it's in a repetitive manner and it's occurring around specific people, you know, if it's just a brief tap, you know, it's not lasting for a long period of time, that suggests that it might be a tic. If it's a compulsion, you know, there might be, you might hear your son say, you would want to ask them, why are you doing this? You know, they would say something like, because they just have to, if it's a tic, or they might say they express their obsession for the compulsion, unless their obsession is something that they might be embarrassed about. But I have seen cases, for example, I had a kid who had a tic where he would elbow people that he was close to, and that was just a pure tic. And he would say that he just felt like he had to do it. That's a really great one. So we're just about out of time with questions, but you can feel free here. I have my email address up here. Oh, and one last question I'll answer. How do I know if I should seek treatment with a psychologist or a psychiatrist? So it really, that's really up to you. You know, it depends on, you know, for ADHD, I suggest going primarily to psychiatrists who specializes in these conditions. And then independently, you would want to see, you know, do you want to start off with behavioral treatment or medication? And that's a very personal decision. You know, either one can be effective. And the ideal treatment is one that involves both medication and therapy. But anyway, if you have further questions, please feel free to email me at michelle.miller@nyumc.org. I have that email up there as well. I also want to let you know that we're going to have 3 series of free workshops for teens with Tourette's and other tic disorders and their parents starting in the end of March. And if you're interested in that, you can email me or call at 646-745-5000, which I have listed up here as well. So on behalf of the Child Study Center, thank you so much for joining me today. And once you leave this webinar, you will receive a survey, and we would really appreciate it if you complete it. You will also receive a follow-up email within a day or two with a link of today's recording presentation. We also have other presentations and webinars that are in our archives on our website. And we also hope that you can join us for our next webinar, Understanding Adolescent Self-Injury with Dr. Randy Proctor, which is on Tuesday, March 7th at 1 p.m. Thank you again. Take care.